treated with the fatigue and MG, and many of them are recent, and I'm not reviewing them in depth tonight. That wasn't the purpose of the talk, but it was interesting to review them, and I have two quotes from two recent studies done in 2018, and the references are there. So Hoffman et al. Said this: our study adds to the scarce literature on fatigue, so there's not much written in fatigue and MG, but demonstrates a high prevalence of fatigue among MG patients and shows a negative impact that fatigue has on their quality of life. They also identified in this study that disease severity, so the more severe your MG was, or the more depressed you were, these were independent risk factors that associated with increased fatigue in MG patients. In another study, they made the point that fatigue in MG is mainly physical, and it's probably related to the muscle fatigability. And these are important factors when we talk about how to deal with fatigue and what other things that can cause fatigue. So what are the general signs of fatigue? So when you're fatigued, you usually move a little bit slower. You may speak slower. You may not speak so loudly. You may have some shortness of breath. And when you're fatigued, you actually may lose your appetite and don't feel like eating. You could be quite irritable, and you could be anxious. Sometimes people who are fatigued just can't even be bothered to take care of their appearance, put on their makeup, or get dressed up because that takes energy. Others may withdraw because of their fatigue, and they have no interest in going out into social events or enjoying activities with their family and friends. Fatigue also can present itself by having increased forgetfulness. I'm just going to present two sort of exemplary cases. These are not real patients, but these are things that I commonly see, and they will tell me they have fatigue. So the first case is a man, the second case is a woman. So for example, a 50-year-old gentleman, he's been diagnosed with myasthenia 2 years ago. He had the typical symptoms of eyelid drooping, neck weakness, swallowing, and breathing issues. He was treated and well controlled with treatments of intravenous immunoglobulin, prednisone, and azathioprine, and he improved over the next 6 months. He was home and doing really quite well. He returns to clinic and says to me, "I feel terrible." He said, and I said, "What's the problem?" He said, "I am so fatigued." So for me, when you see somebody like that and you hear those things, I have to think about what are the things that I need to look at in terms of fatigue. So in this instance, I will focus on sleep and fatigue. So when people talk to me about I'm fatigued, I also ask the question, what do you mean by fatigue? Or are you just sleepy? Is your body fatigued, or do you just want to take a nap? And there's some ways of measuring whether or not individuals are sleepy versus just general fatigue. And one of those measurements is the Epworth Sleepiness Scale. And it just tells you whether or not your daytime sleepiness is normal or whether or not it's excessive. And this is helpful, especially if we're looking at things like sleep apnea as a cause of fatigue. So sleep-disordered breathing or sleep apnea is very prominent in MG patients. MG patients will report that they have poor sleep quality, they don't sleep well, they have excessive daytime sleepiness, they actually may have more limb movements during sleep. And this often can be related to the bulbar or the respiratory weakness in their throat and the weakness of their throat, and also association with the weight gain that patients have on steroids. So the things that when we listen to them and they tell us their symptoms, these are some of the things that they may tell me. I wake up very easily during the night. I'm up all the time. I have to go to the bathroom a lot. I have excessive night sweats. If there's a spouse with them, I may ask them, do they snore? Do they have any morning headaches, or do they feel confused and really sleepy in the morning? Do they actually wake up from their night's sleep and they're ready to go, or are they just fatigued even in the morning? Some other people may even describe generalized body aches. So sleep apnea has many complications. It can worsen your MG symptoms. It can worsen your MG. It can actually cause a metabolic syndrome like diabetes. It can cause hypertension and some cardiac issues. It can cause the pain, muscle pains. It can cause depression, and it also can cause stroke. So it's an important thing for us as healthcare providers to rule out whether or not one of the issues is sleep apnea in terms of your fatigue. The other thing I always look at is medications that can affect sleep, which actually may prevent you from sleeping and giving you more daytime fatigue. Here's a list that was I found on the internet, but there's lots more. And in many cases, I will review the patient's list to see whether or not there's something that stands out that may be causing some of their difficulty sleeping or their daytime fatigue. Or I may even ask them to go to their local pharmacy and have them actually review every medication they're on and whether or not that could be one of the medications that's causing their fatigue. So as you can see, trying to discern what causes fatigue in MG is very multifactorial and it's very complex. So both prescription and non-prescription drugs can affect sleep, which then can have you have fatigue. Don't forget about things like alcohol. It does not help your sleep. In fact, impairs a good sleep. Caffeine impairs good sleep. Cigarettes impair a good sleep as well. Here are some other medications. Some of the antidepressants, although they're supposed to help you for depression, can actually interfere with sleep. And some of the medications that we use for these leg movements may interfere with sleep, but also may help the leg movement. So it's a little bit of a catch-22 where we're trying to take care of things on both sides of the fence. Prednisone, of course, does interfere with sleep, and hence the reason that we try to keep that medication as low as possible. And also we ask our patients to take it in the morning rather than in the afternoon or evening. Chantix is also another medication that can cause difficulty with sleep and then affect fatigue. This is not meant to be a comprehensive list, but just to give you an idea that there are many, including the non-prescription drugs. Restless leg syndrome is very common in MS patients, in MG patients, and that also should be ruled out. This can be ruled out, including the obstructive sleep apnea that happens in MG patients or even in just normal individuals by having an overnight sleep study. So the key points from this part of the presentation is that sleepiness and fatigue are not the same. And this may not always be due to your MG. So one always needs to have an open mind. Present it to your neurologist or your family physician is that not all your symptoms are related to MG, and there's lots of other reasons. Sleep apnea, restless legs, and insomnia are all treatable problems that may help your fatigue and your sleep. And of course, be proactive, knowing when to see your doctor about your sleep issues. So the next exemplar case, not a real case, but something that I always think about, is a 35-year-old woman. She's been diagnosed with MG 2 years ago, and her symptoms of MG, typical again, eyelid droop, neck weakness, swallowing, and breathing issues. So men and women can both present with the same type of MG symptoms. She was also treated with the same medications, IVIG, prednisone, and azathioprine, often the first-line therapies that we use. And she also improved over the next 6 months, and her MG was, those symptoms of her MG were quite controlled. However, she also says to me, my number one issue is fatigue. So what factors do you need to think about here that may be different from the factors that we thought about with the gentleman and where I discussed sleep as a problem? So these are the things that I try to ask my patients, or I ask them to think about, and so I'm asking you tonight, if this is one of your symptoms, these are the things that you can think about. Are there any other MG symptoms that I'm experiencing, or is it only fatigue? If it's only fatigue, then it's probably not related to your MG, but that could be explored with your doctor. How long has this fatigue been your number one issue? What time of day do you experience the fatigue? Is it at night? Is it all day? Is it first thing in the morning you wake up fatigued? What activities make you fatigued? And then what are the things that would help your fatigue? What makes your fatigue worse? And do you have any other health issues that could contribute to your fatigue? So weight loss and weight gain are both issues that could contribute to your fatigue. Mood, sleep, menopause, menses, all these things. And Dr. G will be talking about some lifestyle changes and the lifestyle effects with fatigue. And then again, how you're managing at home and at work. And this is for both men and women. We have, 2 jobs, and especially if you have a family, and all these can contribute to your fatigue. There's other medical causes of fatigue that I like to have ruled out if individuals do describe this as their number one issue. So I look at their side effects of their drugs, of course, but it's not uncommon to have anemia. And so especially in women who are still having menses and having blood loss, anemia can be a cause of the fatigue. Thyroid issues, quite common, diabetes or other autoimmune diseases. MG patients do have an increased risk of other autoimmune diseases, and so regularly I will check their thyroid status, their B12 status, and for whether or not they are anemic. Because again, these are treatable causes and they're not necessarily related to their MG. So how would you assess, is it fatigue related to your MG or not? I usually do the regular MG physical examination, examining the eyes, the face, listening to their speech, talking about their swallowing, may even watch them swallow some water, assess their breathing, and then assess their neck and limb strength with repetitive movements, and can I overcome them. Also important is that MG patients have their ongoing annual physical exam with their general practitioner to assess whether or not the fatigue is related to other issues. From my perspective, in MG patients, I would probably also look at their pulmonary functions and their breathing tests, may order overnight sleep studies if that's appropriate and it's the right setting, and we've talked about sleep apnea, how that could be assessed. I may even do some electrophysiology studies just to see whether or not there is a component of the MG still being quite active, and it helps me sort of assess what is MG and what's not. And then, of course, I may order some blood work to rule out those other causes of MG, of fatigue in MG patients. But there are other issues that can impact fatigue in MG patients, and Dr. G is going to talk about the next 2 topics, inadequate MG control and lifestyle issues.
Dr. G, we're not able to hear you. Give us one moment. I know Dr. G was using his computer audio, which he's having a little
Yes,
bit
can
of
you hear
trouble
me now?
with. Yes, perfect. Thank you so much.
Excellent, thank you. So I want to thank Wilma for presenting a very up-to-date and a thorough review of fatigue in MG. In my own practice of MG, a very common complaint I hear from my patients is fatigue. And as Wilma pointed out, it becomes very important for us to tease out what is MG-related fatigue, which is a bit more complex, and what is fatigue in general. We have a saying, just because you have MG doesn't mean you can't have other things going on. And sometimes my patients go to their primary care physicians with fatigue, and the first thing they hear is, which MG, talk to your neurologist. And they come to me and they have some other things going on. Their thyroid is low, their blood counts are low, they have sleep apnea, and many other things that come up out there. So it becomes very critical for us to figure out what is MG fatigue, what is fatigue by itself, and sometimes both can coexist, and we see it often. My part of the talk is focused on two things. The first thing I'll be focusing on is management of MG itself. A common reason I get referral from my colleagues and other neurologists and primary care doctors is that we are having a hard time controlling the MG if the fatigue is bad. So I'm going to focus very briefly on some treatment aspects of MG, and then point out some pitfalls and pearls in this management of MG that can happen. That could be making the MG worse and the fatigue worse. A quick question there for all of you to think about is, how many of you have doctors who routinely do something called MG-ADL? It's MG, and ADL is A as in apple, D as in David, L as in lion. MG-ADL. It's a quick score that I do on my patients with MG routinely when they come to see my clinic. It gives me an idea about how well their MG is being controlled, and how much it is affecting their day-to-day life. MG-ADL is Myasthenia Gravis, activities of daily living, and MG can have an impact on how your activities of daily living are being affected and so on. And it takes about a minute or two actually to do it, and it's very useful for me. And I keep a track of that every time the patient comes, so I get an idea on where the MG is and what medication changes I may need to make or not make with regards to management of MG. Can everyone hear me well? I just got a note there from Kathy saying that it's not clear, so I'm trying to make sure it's clear. Can everybody hear me? Can you send me a message there?
Yeah, I hear. I've been seeing in the chat box that it's breaking up. It's a little tough to hear. Do you happen to have a landline you're able to call from?
Yes, I can try I can try it again. Let's see. Can you hear me now if I'm like this?
I can hear you fine.
Okay.
And I'm hearing from other participants that it sounds better. So I think we're good.
Okay, let me do this way. Hold on just a minute. Okay. So that's a common reason I see from my patients that their MG is not well controlled, and I do this MG activities of daily living, and I keep a track of the score to see what level their MG is, how are they before, are they progressing, are they the same, are they getting worse, are they improving. And I would strongly urge many of the participants that are here today to talk to your neurologists or physicians, whoever is taking care of you, to do this MG-ADL. It doesn't take that long. And it's really useful way to track myasthenia. So that's the first point there. So once I do my MG-ADL, I get an idea about how well the MG is controlled and what else is going on. The treatment for MG, as we all know, consists of commonly prednisone, which is the first line of treatment. In many cases, in addition to prednisone, we have steroid-sparing agents and immunosuppressive agents. In some rare cases, we also use IVIG as a maintenance treatment. On some even rarer cases, sometimes we use plasma exchange as a maintenance treatment for myasthenia. In most cases, however, IVIG and plasma exchange are used for exacerbations. In addition to that, we use pyridostigmine. Pyridostigmine is it will help you, but here is the point I want to make here in terms of MG medications. Pyridostigmine is useful, but in a patient who is really well controlled with medications, such as prednisone or other immunosuppressive agents, you typically don't need that much pyridostigmine. And in fact, I have many patients whose MG is really well controlled, and they don't take any pyridostigmine. So while pyridostigmine is helpful to treat your symptoms in a patient who is really well treated, you don't need that. And that's a way for us to say whether the MG is controlled or not, whether the fatigue is better or not. In addition, of course, now we have eculizumab that's been recently approved by FDA for treatment of seropositive generalized myasthenia gravis. And of course, there are a host of new medications that are in clinical trials that, if they show results, will be coming to our clinic soon. So the landscape of MG treatment is very rapidly expanding. A common scenario I see with MG and fatigue with medications is that their medication doses are lower. So I'll give you an example. I recently saw a patient was referred to me because they felt their MG is not well controlled. Patient was seropositive, was on prednisone 15 milligrams every day. Patient was taking methanol 50 milligrams almost 5 or 6 times a day. Still had a lot of fatigue. He was a farmer. He couldn't do his work and felt that he's not helping his family, and just felt fatigued and weak and just miserable overall. When I examined him, he had all the classic features of MG. He had droopy eyes, nasal voice, couldn't count more than 30 on what we call a single breath count test. And of course, fatigue was a big thing for him. It was affecting his work. All this patient needed was to increase the dose of his prednisone so his MG gets better. It's what we did. And we are continuing to follow him, and as we increase the dose, he feels stronger, his fatigue gets better. And that's something to keep in mind, that in many cases, the simplest solution is to make changes to the medication and increase the dose or alter the dose of medication. I had another patient that I saw recently, and the patient had been stable on medications for a while. Patient was on prednisone and mycophenolate. The prednisone dose was being tapered, and the mycophenolate dose was kept at 250 milligrams twice a day. And then, of course, the patient felt that the MG is not being well controlled, fatigue is worse. And of course, the neurologist had referred the patient to me to see what else needs to be done. And in this case, as the prednisone taper was being done, he was not on adequate doses of mycophenolate. I had to increase the dose, and as I increased the dose and with time, the symptoms got better, the fatigue got better. So in some cases, of course, despite adequate treatments, despite adequate doses, you may need more than one treatment. I have patients who are on prednisone, who are on pyridostigmine, and also do maintenance immunoglobulin. That's the only way their MG symptoms get controlled. That's the only way their fatigue gets controlled. So the flow chart
Hi,
I have here. Yes?
Dr. B, I'm sorry to interrupt. Some of the participants are asking if you can speak a little bit slower because the audio quality is a little tough to hear.
Okay. Now can you hear me better here? I will try to slow down. So the flow chart I have here is a bit complex. The take-home point here is we have lots of different treatments for MG. And while we have different treatments, you will have to discuss with your neurologist on which combination of treatment works best for you. The other thing I strongly recommend is to make sure you are on adequate doses of these medications. Sometimes the issue would be just the dose is not sufficient. At other times, the issue is that you need to be on a different medication. The medication that you're on is no longer helping, and you may need to change the medication. So there is no, unfortunately, myasthenia treatment in many cases ends up being trial and error. And you have to work closely with your neurologist to see which of the medications works best for you, or which of the combination of medications works best for you. And that's a key take-home point. So there are a lot of treatment options. If your MG is not being well controlled, 2 questions you need to ask yourself and ask your neurologist. Am I on the right dose of the medication? Am I on the right medication? I think those 2 questions will help you to figure out and whether your MG can be controlled better or not. And the MGFA website has a really nice booklet on all the different treatment options and doses and so on, which I encourage my patients to use and look up so they know they are well aware and educated about medications. So those are the 2 critical questions I would really suggest that you ask yourself. And keep in mind, the 3rd question you want to ask yourself is, how much of pyridostigmine am I taking? And just because you are on pyridostigmine and it's helping you, if your MG is really well controlled, you won't need as much of pyridostigmine. So if it turns out that you are taking multiple doses of pyridostigmine, you may again want to question as to whether your MG is well controlled or not. So these are the 3 critical questions I would encourage you to ask yourself, and when you see your doctor, make sure to ask these questions. Am I on the right medication? Am I on the right dose of the medication? And how much of pyridostigmine am I taking to control my symptoms? 3 questions will give you a lot of answers. And of course, if your doctor is not doing the MG-ADL, I would suggest to talk with them to see if that can be done, and your MG symptoms and MG scores can be tracked, so we know where you are. That's with regards to the treatment I just want to highlight. And this is again my top 5 recommendations that I do. You need to find a good neuromuscular specialist who is very familiar with MG and MG treatment. You need to work closely with your primary care physician, because many of these treatments themselves cause a lot of side effects, which in turn can cause fatigue and other MG complications. You want to, of course, be compliant with medication. I cannot tell you how many times I have had patients come to my clinic telling me that their fatigue is worse, their MG is worse, and when I dig deeper, the reason comes out that they are not taking their medications as prescribed, or in many cases just not taking the medication. I had a patient, I prescribed her prednisone, and she just stopped taking it one day and came to my clinic saying that she's severely fatigued, she cannot go to work, she cannot take care of her children. and I was trying to figure out what made her MG worse, what made her fatigue worse. It's just that she was not on medications. So, of course, staying compliant and taking them on time makes a big difference. And this is something that I always encourage for my patients to stay active, but do them in moderation. And of course, rest of things, eat well and try to avoid infections. And these 5 things, along with the questions you want to ask yourself about MG treatment, will really help you to remain focused on MG. So these are the common things I always tell my patients about in managing MG. The next part I want to focus on is how do you manage yourself with MG? And that's a critical question there. Despite adequate treatment, despite all the medications, despite following all the doctor orders, you still have fatigue and muscle weakness with MG. Unfortunately, that's the nature of the disease. And I always tell my patients that you have to follow certain things, make changes to your lifestyle. And here are a few things that I commonly suggest. The most important thing I suggest is to plan your activities the day before. And that really helps you to have things assembled before you start. Conserve energy where possible. When you can sit, please sit. You don't have to stand. It seems very simple, but it's hard to do those. Make sure you take breaks periodically. Again, very hard to do. We are all type A people. We like to do things, get going, and we want to get things done. But you need to find ways to take rest periodically. Use a cart, use a basket to move things, and take your time to do them. You don't have to rush. Use power tools where possible. I don't want you to live in a bubble. I don't want you to stop doing things. But where you can find ways to reduce muscle overactivity and fatigue, we need to do that. So I always encourage that. In terms of personal grooming, I always recommend a shower stool or a stool in the bathroom, wherever you want to sit and do things. Rest your elbow, rest your arms, take breaks. And when you take a shower, make sure it's a warm water and not a hot water. Hot water can make your MG symptoms worse, so we recommend using warm water. With regards to medication, keep Mestinon with you. In case your MG symptoms are worse, you always have that as a backup. But again, keep in mind that if your MG is well controlled, you won't need Mestinon. You don't want Mestinon controlling your life. Use watch or cell phone with an alarm to make sure you are taking medications on time. If you are going to be on a new medication, make sure you talk to your MG doctor. And this is something I make sure I tell my patients. Again, the MGFA has a list of medications that need to be used cautiously with MG. So I always give a printout or a handout of that list to my patients and tell them to make photocopies of those so they can give it to all doctors. Certain medications can make MG symptoms worse, fatigue worse. So in some cases, if you need them, you need them. But it would be good for your primary care or any other specialist doctor to discuss that with the MG expert before moving forward. Most of my MG patients get a handicap parking sticker. Whether they use it or not, I make sure I give it to them so they have easy access to parking. I also make sure that I tell them to use a scooter, especially when they're traveling, shopping, and so on. And I also make sure I tell my patients to have an eye patch with them. and this seems, like people ask me, why is that? And I can tell you a story of a patient of mine. He was driving on the highway and then suddenly noticed that he's seeing double. His MG symptoms got worse and he couldn't drive anymore, had to pull over. So those situations sometimes come. Having a eye patch handy with you will be really helpful. And with regards to eating, many of my MG patients dread going to restaurants with their family and friends, and that's true. But if you follow certain things, that would be, you could still enjoy time with your family. And one thing I would recommend is to use semi-solid food and have meals with cold beverages rather than hot foods, which again can make muscle weakness worse. And make sure to grind meals as much as possible. And cramps are very common in MG. Tonic water is something we use for cramps very commonly, but it can make your MG a bit worse. So that's the reason why I have it there. Alcohol can make MG worse. Temperature changes can make MG worse. And we always recommend, so the patient that I told who was a farmer, I try to make sure that he does his work very early in the morning. So he wakes up around 5, gets most of his work done by 8, 8:30, and he's back home. So he's not working in the hot field all day. And the last thing is critical: avoid stressful situations. It's a hard thing to do. There is stress everywhere, at work, at home. But finding ways to work around your stress will really help with MG symptoms and fatigue. Stress can trigger MG symptoms to get worse. Stress can make fatigue worse. If you're able to find ways to work around them, that really helps with your overall well-being. These are the few things I always advise my patients, in addition to, of course, managing their medications and other medical issues. These are the few slides I had. I and Wilma are happy to take any questions everyone has.
Thank you so much, Dr. G and Wilma. So I have a few questions from the chat box. And anybody else, please keep feeding questions through the chat box, and we'll pose them to the presenters. The first question that we have is from Janet. Does Mestinon interfere with sleep?
I can answer that question. It's Wilma. Can you hear me?
Yes.
Okay. So technically, Mestinon does not interfere with sleep. However, Mestinon can cause urinary frequency and urgency. And if you already have that problem, certainly that can be the reason you're getting up more frequent at night, because you have to urinate more frequently, which is a side effect of Mestinon. So that's the possibility of how that could interfere with your sleep.
Another question that we have is, can fatigue be brought on by weakness of the heart muscles caused by MG?
I can partly answer that, and I will have Wilma also pitch in there. Typically, MG should not affect your heart muscles. Now, there have been multiple reports of different kinds of heart issues with MG patients that have been published. And we, in fact, have a few patients in our clinic who developed what we call Takotsubo cardiomyopathy, which is basically a broken heart, which of course made their MG symptoms worse and so on. But typically the heart is not affected in MG. Again, there are exceptions to this, but that would be the take-home point. If there is heart involvement, the question would be what's causing it. And before we jump and say it's MG, we need to rule out everything else.
So I would agree, and I would probably strongly say that it's heart issues is generally not MG, and it would be the last thing on my list. However, obstructive sleep apnea, if untreated, can actually cause heart issues. So it's not that we don't think about it, but certainly it's not directly related to the myasthenia.
Thank you both. The next question that we have is, do outdoor hot temperatures impact fatigue and other MG symptoms?
Yes, it does. Definitely hot temperatures can make some of the MG symptoms and fatigue worse. And that's one of the slides I had there, where you, as much as possible, try to avoid them. Some of my MG patients say that if they wear a cooling vest, it does help them. But of course, I have not found that to be true among all the patients. So that's again, it's we try to avoid this too hot or too cold of a temperature change.
Thanks so much, Dr. G. A question that's somewhat related to the earlier one, does MG affect the heart muscles?
No.
No. I mean, as we discussed, it's you should look for other causes. So that would be my take-home point.
Thank you. A question that we have is the MG-ADL, when my doctor does all the physical tests, like squeezing my fingers, looking up to see about drooping eyelids, keep your knee up while she's pushing it down, is that an example of the MG-ADL?
No, that's a part of the physical exam that we do, basically the neuro exam. MG-ADL is a set of questions that we ask the patient about grooming, about eyes, about sitting, and so on. And it's, I don't know if there's a way we can send a link to all our participants about the MG-ADL or point them towards that online. But it's a different set of. I'm sorry?
We definitely can. I can send it over now.
Yes, because that's a different set of questions that we ask, and it's very useful to know that and have that score with us.
If I'm correct, I think it's on the MG app, is it not?
Yes, it is on the MG app.
It's on the MG app. The people.
Yes.
So some of my patients will who use the MG app, they will complete the MG-ADL, say, once a week or once a month, and then when they come in, they at least then have a sense of what their MG's been like in the last 6 months. So I find it helpful if people then do complete it on their own before they come in, so that I can get a sense of what was it like. It's like taking your blood pressure once a week. Bring me in your blood pressure weekly for the last 3 months, and then I have a sense of whether or not you've got high blood pressure.
Yep, I agree with Wilma. That's definitely a possibility. The area where I practice, it's a rural area. Most of my patients are on flip phones. So I do the old school way of paper and so on. But yes, the app is really useful, and you can get the score and you can take it to your doctor, keep a track of it, and take it to your doctor actually.
Thank you both. One question that somebody posed is, have any patients reported any relief using medical marijuana?
I will jump, and then maybe Wilma can also chime in there. There is no studies done on medical marijuana and MG. In fact, there are no studies done on medical marijuana and any other neuro condition for that matter. So I have a neutral opinion on that. people claim that medical marijuana works for everything, from Alzheimer's all the way to cancer. So I have neutral opinion, and I have and there are no risks of marijuana as such. So I would definitely not recommend doing that.
Yeah, I would agree.
Go ahead, Wilma. Sorry.
No, I would agree. I mean, there's no evidence that marijuana is going to improve your myasthenia gravis. We have great treatments for myasthenia gravis, and I would endorse them. Marijuana can also make you increase your appetite, which then puts on weight. It can make you fatigued. So it also has side effects. So again, don't think of something that's quote unquote perhaps natural because it grows in the ground as still a good product to use, and it's going to make you better than the ones that we give you, which sometimes people say are so toxic. We really are quite aware of the toxicity, I think, of these medications, but when patients are really ill, I'm very grateful that I've got something to give patients that I know will work.
Hi, everyone. I also sent a link. MGFA recently updated in partnership with our medical and scientific advisory board members our statement on medical marijuana. So that has specific information regarding MG and basically supports everything that was just mentioned here. But if you want something that's more in depth, I sent the link over the chat box as well.
Excellent. Did you send it to me as well?
Definitely.
Thank you.
A question that we have is, where can somebody obtain a list of adverse medications?
Again, if you can send a link, I know you guys recently updated, but it looks really fancy and nice now. So,
thank you. Yeah, so we can send a list of cautionary drugs. We can send it over email, but we also can send it via mail as well for anybody who would prefer to receive it in print.
And again, is that updated on the MG app? Because I thought it was on there as well.
Yes. Another question that we have is, why do many MG patients experience cognitive fatigue even when physical symptoms are well controlled?
So cognitive fatigue, we all experience it, including me, and it's now 9 o'clock at night, and I'm cognitively getting quite fatigued. So I don't think it's specific to MG if your MG is controlled. But your MG, although it may be controlled in the sense that you think it's controlled, it still may sort of be there as an underlying, you're on drugs to help it get controlled, or it's there. So I wouldn't blame everything on MG, but it can still be there. And the ways to sort of look at cognitive fatigue is when we're tired, our brain gets tired, and that happens to people who have MG and people who don't. And so then try to mitigate that by, taking a nap or doing when's the best part of your day, just sort of breaking up your day and doing all that conservation of energy. I don't think there's anything specific related to MG that makes it more susceptible when your MG is controlled.
Yes, I agree with Wilma on that. And the other thing sometimes you can think about is if you have undiagnosed sleep apnea, that can affect some of your cognitive functions as well. So again, that's where I screen for sleep apnea, and if needed, do testing for sleep apnea. And the other part to keep in mind is, MG is a overwhelming and all-encompassing disease. It does take control of your life, and you are so focused on MG, taking medications on time, doing the right thing. That's a stressful situation, and it becomes really hard to focus on everything else. And that's and that's a part of the disease there. You are fighting MG, you are fighting the medications, and you are fighting the side effects of those medications. So you're basically fighting three battles right there.
Thank you both. Another question that we hear is, do you find that treatments are the same or different for seronegative patients?
The treatment should be the same. The only exception would be eculizumab, where it's not approved for seronegative but only for seropositive patients. But in many cases, the treatment that we do for seronegative is very similar to seropositive.
I agree.
We have a few more questions and then we can wrap up. Have you noticed that MG patients get tremors more frequently when they are fatigued?
So just on that, it depends on what kind of tremor they are talking about. Just because you have MG doesn't mean you cannot have other things going on. And there are lots of reasons for tremor. Now, of course, if you have MG and weakness and fatigue, that itself can cause tremors. But again, the question would be, it needs to be carefully figured out as to what kind of tremors they are.
I agree. And then there's just one other thing that I have seen and I note is if people have been on prednisone for a while, some people for some reason will have more of a hand tremor that may go away when the prednisone is decreased. So just something to think about as another cause. But I agree, it needs to be fully investigated first. Don't just think it's the prednisone.
Thank you. And somewhat of a related question, maybe a slightly off topic, but a few people are asking whether mestinon or prednisone, if they cause cramping.
Mestinon can. That's one of the side effects of that. I've not heard prednisone causing cramping. I don't know, Wilma, if you have had any experience with prednisone causing cramping.
So I have, and commonly the first thing I would think about is, are they hypokalemic? So I would check their blood work in terms of their potassium being low. But both prednisone and, in my experience, and mestinon cause cramping. Mestinon's worse than prednisone, but if they still have cramping and all they're on is prednisone, I may even treat them with potassium to help with the cramping because it does help.
Thank you so much. So I think that wraps up our one more question. So for sleep, a CPAP or a BiPAP is better?
I think, Wilma, you can answer this and I will chime in. I know we had a discussion on this at the MGFA
for sleep
meeting.
Apnea, sorry.
Okay, so for sleep apnea, CPAP and BiPAP are two different mechanisms, two different machines that are used for different types of sleep apnea. So it's really important that a respirologist determines whether or not you need a CPAP versus a BiPAP. It's just a different, they work in different ways. It's sort of pushing air in or pushing air in and out in the easy ways. But Dr. G probably can talk about this more differently. So you can't compare the two. It depends on what you need based on your sleep studies and your respiratory assessment.
Yes, I agree with Wilma, and you really need a sleep study to figure this out. It also depends upon how severe or how controlled or not controlled your MG is and what other medical issues are going on concomitantly. So it needs a in-lab sleep study to be more precise. I would not do a home sleep study in MG patients to get a clear answer on which one is the way to go.
I agree.
Okay, so we'll take that moment to wrap up. Thank you all for your questions. Many thanks to Dr. G and to Wilma for taking time out of their day, and we definitely don't want to fatigue them anymore since it is getting late. So thank you all for your wonderful questions, for taking time out of your day, and special thanks to Dr. G and to Wilma. And any other questions, you can always feel free to contact the MGFA at 1-800-541-5454 or at mgfa@myasthenia.org. We also have recently updated our website, so you'll find some new information on there that may not have been on our previous website, so we do encourage you to check that out and to contact us for any materials or additional information. But thank you to everyone, and I hope everyone has a great night. Take care.
Thank you.
Thank you, everyone.